Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 504 of our pharmacotherapy series, which majors in anemias. The next case reads, TBC is a 4-month-old girl who has recently been diagnosed with sickle cell anemia. Both parents positive for sickle cell trait. Her older sibling is positive for sickle cell trait but is asymptomatic. So my first question to you reads, how does TBC's diagnosis affect her risk of infections? TBC is at an increased risk for infections because sickle cell anemia causes defects in splenic function, complement activation, granulocyte function, and B-cell immunity, as well as micronutrient deficiencies. Impaired splenic function increases TBC's risk for infection from polysaccharide-encapsulated bacteria such as Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis, and Salmonella typhimurium. These infections occur most frequently in early childhood, although TBC will have a lifelong increased risk of infection. Pneumonia caused by Streptococcus pneumoniae, Mycoplasma, or viruses can worsen hypoxia, causing progression to vaso-occlusion and acute chest syndrome. Pulmonary complications from pneumonia or vascular occlusion can also lead to right-sided heart failure. Other infectious conditions such as osteomyelitis from Staphylococcus aureus or Salmonella typhimurium or urinary tract infections caused by Escherichia coli are common complications in patients with sickle cell anemia. My next question to you reads, what preventive measures should be taken to prevent infections in TBC? Patients with sickle cell anemia should use general preventive measures, such as frequent hand washing, avoiding sick contacts and thoroughly cooking foods that may carry salmonella, e.g., chicken or eggs. Children should be closely monitored for symptoms and antibiotic therapy should be instituted at the earliest sign of infection. Prophylactic administration of penicillin has significantly reduced morbidity and mortality from pneumonia in children younger than 3 years of age and is recommended to be continued through age 5. Patients such as TBC should receive 62.5 mg twice daily during the first year of life, increased to 125 mg twice daily for ages 1 through 3, then 250 mg twice daily until the age of 5. The U.S. guidelines recommend discontinuing penicillin prophylaxis at age 5 unless the child has undergone splenectomy or has had an invasive pneumococcal infection. Vaccines that are recommended for patients with homozygous sickle cell include all standard pediatric and adult vaccines. TBC also should receive the pneumococcal 23-valent polysaccharide vaccine at 2 and 5 years of age, with a booster every 10 years throughout her life. Because patients with sickle cell typically respond poorly, only 50% of patients will be protected by vaccination. Therefore, there is a continued need for penicillin prophylaxis in young children. TBC is now 3 years old and presents with pallor and significantly decreased activity. Her mother notes that some of TBC's daycare classmates have been experiencing a mild viral illness and rash. Her pediatrician obtains a CBC with the following results: a hemoglobin of 6.2 grams per deciliter, a hematocrit of 18.1%, a platelet count of 97,000 per microliter, a reticulocyte count of 0.5%, a WBC count of 6,000 per microliter. So my next question to you reads: what is a potential cause of TBC's symptoms and how should they be managed? Human parvovirus, abbreviated as HPV, B19 is a common cause of transient RBC aplasia, with up to 67% of infections resulting in a hematologic change typical of aplasia. It is a common, highly contagious childhood infection with more than 70% of adults testing seropositive. Nearly 70% of all homozygous sickle cell patients are HPV B19 seropositive by 20 years of age. In normal individuals, the infection is asymptomatic or presents as mild flu-like symptoms with or without a generalized maculopapular rash. The virus also infects RBC progenitor cells in the bone marrow, causing a temporary 7 to 10 day cessation of erythropoiesis in 65% to 80% of infected individuals. In normal individuals, RBC lifespan is 120 days and this does not typically produce symptoms. Patients with sickle cell anemia have an RBC lifespan of 5 to 15 days, so the temporary break in erythropoiesis leads to a severe anemia. Thrombocytopenia has been noted in approximately 1/4 of those infected, with less than 20% of patients experiencing neutropenia. Although most children recover within 2 weeks, the majority will require blood transfusions to manage anemia. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 505.